chairpersons and my dear friends. I've been asked to speak on reporting a complication and art. I have tweaked the title a little bit. I've called it Dealing with a Complication and Art. So none of us are going to live long enough to commit all the complications ourselves, leave alone finding their solutions. So the best policy is to learn from each other, because there is no need for each one of us to reinvent the wheel. So my simple advice to many of you is, rather than discussing successes on social media or in luncheon meetings, it's a good idea to discuss complications, because there's a lot to learn from them. What I'm going to do over the next 10 minutes is to share with you some random thoughts on complications that come to my mind after having dealt with them for 3 long decades. I think this talk would be more relevant, or probably only relevant, in the developing world, where I have some experience. In the developed countries, dealing with complications and counseling families probably is a different ballgame altogether. So these are some of the lessons that I've learned over years, that complications don't knock before coming. They come from nowhere as a bolt from the blue. In sports, you must have heard, it ain't over till it is over. In pediatric interventions, or for that matter, in adult interventions or in surgical interventions, it ain't over even after it is over, because complications may come hours, days, weeks, months, or even years after the intervention is done. I think alertness to recognize and preparedness to deal with them are the 2 most important qualities of an interventionist. Communicating with the patient and the family, especially during difficult times and also during normal times, is an art. Unfortunately, in India, it's neither a part of our curriculum nor a part of our evaluation. So we hardly learn to communicate with patients and their families till such time we are in practice. And probably by that time, it is too late to learn. But I would say that earlier you learn this art, better it is, because most of the problems, and when I say problems, I mean medical legal problems, arise due to improper communication or lack of it. In India, apart from playing a role of a physician, patients and their families expect you to play God. So all the questions, whether to intervene, how to intervene, when to intervene, have to be answered by the physician himself. When you try and involve families in decision making, do you agree with this? They will say, "Aap Bhagwan hai. Aap jo bolenge, hum karenge." So when they keep repeatedly telling you "Aap Bhagwan hai," many of us actually start believing that we are God. But remember one thing, we are as human as our patients or their relatives. And we are capable of making mistakes, and we are capable of getting into complications. So don't be under this misconception that you are God. I think the best policy is to remain grounded, because if you start believing that you are God, the patient's relatives will really think that you are one. And then when you get into complication, you are no more a God, but then you become a demon. I think preventing is certainly a better way to deal with complications rather than dealing with them when they actually occur. So the best way of preventing complications is to plan your work to your plan, put the systems in place, have checklists. Don't take things for granted. Learn to expect the unexpected and be prepared for surprises and complications at all times. That is the best philosophy. You should be ready for these kinds of things to happen during procedures. Complications is a part and parcel of interventional cardiologists. You just can't avoid them. There are only 3 types of interventionists who have 0 complications. Either they don't work, or they lie, or they are God themselves. If you can't deal with complications emotionally, quit the subspecialty of transcatheter intervention. There are many other subspecialties where you can be at peace with yourself and you will be able to deliver much better. No matter, you may blame complications on patient characteristics, disease characteristics, device characteristics, 10 characteristics, but I think more than 90% of the times it's human error. And why does this human error occur? because we tend to take things little lightly. So remember that there is no slam dunk in intervention. Never underestimate even the simplest of the interventions. Do every step as if you are doing it for the first time. Don't let your guards down. And most importantly, do not flout the basic principles of interventions. For example, pushing a wire into a catheter or device into a sheath without aspirating, or pushing against a resistance. These are some of the simple things, but these are the places where if you do things against these basic principles, you're likely to get into problems and you're going to kick yourself for that. So in short, do not take anything for granted. One of the most important things is the pre-procedural counseling. That will make your job much simpler if you have to counsel the families due to complications if they were to occur. And I think what you should do is don't let it be done by your junior or by some colleague. I think it's better to do it yourself. One of the things that I've learned over the last 10 to 12 years, and I've made it a part of my practice, is to have one more counseling session, apart from the one that you're having in your clinic or in your consulting room, is to have one more counseling session on the morning of the procedure, during which time you reiterate the salient features of the procedure, remind them about the finite complications. It's a good idea to ask them what did they understand so that they utter those words, those complications themselves. And if they are not willing to do that, the second best thing would be to ask them some leading questions to confirm that they have understood what actually you have said. During counseling, the best policy is to be truthful about the indications, about the safety of the procedure, about its efficacy, so on and so forth. Tell them everything that you know. Never ever scare them into doing the procedure. Don't tell them that if you don't do this procedure, you are going to die. Also, don't tell them that it's the best thing on the earth to have this procedure done, as if you are going to go flying the next day. I think this is what I call selling the procedure. So don't sell the procedure. Be matter-of-factly, but not indifferent. Be empathetic, because empathy is what patients and their families need at that point in time. Complications are of many types. They could be minor, could be sorted out in the cath lab itself. They could be intermediate severity, may need a transfer to the ICU or the OR, or maybe major, which may have life-threatening implications requiring cardiopulmonary resuscitation. When it comes to counseling the family, more so after major complications, do it yourself, if possible. Of course, if you're attending to the patient, you can't do it yourself, but otherwise, best thing is to do it yourself. Never counsel a family in the corridor. Take them to a counseling room, make them sit, make them comfortable. Let the family know everything about the complication, explain to them the sequence of events as they occurred, enumerate all the steps that you have taken. Let them know what your plan is from now onwards. There should be a complete clarity of thought, because that will result into clarity of action when you start dealing with these complications. Never, ever blame your colleague for a complication, not only in front of the family, but not even privately. You must lead from front. As a leader, you have taken bouquets for the successes. You should be ready to take the brickbats for complications. Never be aggressive with the family. Family is under stress, so they are likely to be aggressive. Sometimes they are going to be even abusive. Do not try to match their aggression, and certainly never be abusive. It is not befitting our profession. So no matter what the provocation is, you need to keep yourself calm. Your job is to save the child, to reduce the morbidity. So work towards that goal. It is not the time to think about what will happen to me. Will I be pulled to the court of law? Will I get penalized? I think that will cloud your thinking. So avoid thinking of that. Be positive and do everything that you can under the circumstances. Not only that you should do everything, but it should be seen that everything was done. Don't think about the cost, how much it's going to cost if I use this, if I use that. I think human life is priceless. Keep the family in the loop all the time. Do not ever abandon the patient. Cancel all your appointments, cancel your schedule till such time either the patient settles down or he is handed over safely to your surgical colleague or the intensivist, or unfortunately, if he succumbs. If he does succumb, it is you who must break the news of death. Neither the sister, nor your colleague, nor your assistant, nobody. Don't tell your registrar or nurse to do that job. It should be you who must break this news. When you will break this news, you will have to listen to the family. You'll have to answer their questions. Never try to dodge any questions. What you know, state upfront. What you don't know, say you don't know, because there is no room for conjectures. I think honesty is the best policy, because if you speak one lie, then in order to defend that lie, you will have to speak 100 other lies. And when the thinking is clouded, it may not be easy to keep lying all the time. So I think honesty should be the best policy under the circumstances. So ladies and gentlemen, our job as interventionists is like that of a wicketkeeper in cricket. You may collect 1,000 balls behind wickets, but you won't be pardoned if you let go one snake. So you may do 1,000 interventions successfully, but one complication and the family is not going to pardon you. In cricket, there is a second chance, there's second innings, second test. In our profession, there is only one chance. So as I gray, I have realized that it is not our ability to intervene successfully, but our way to deal with complications, what separates men from boys in this exciting field of structural and congenital interventions. Thanks for your patient hearing, ladies and gentlemen.